Okay, now in terms of the actual drug regimens that we're using in TB, here's a standard regimen: isoniazid, rifampin, and pyrimethamine. Now, pyrimethamine is often stopped 2 months in non-HIV patients. Alternative regimens may be isoniazid and rifampin for 9 months, or isoniazid and ethambutol for 18 months. In patients who have resistance, that resistance is usually to isoniazid. We use rifampin, pyrimethamine, and ethanolamide for 6 months, or rifampin, pyrimethamine, and streptomycin for 6 months. So this can be a downloadable file so that you can have a look at it on your own. I also recommend that you have a look at the treatment regimens for your part of the country or of the world. And a really good example of this is the difference between, say, California and Alaska, or even between the US and Canada. So it's interesting to see that the Yukon Territory is right next door to Alaska, they're neighbors, and they will have completely different treatment regimens. Germany and Poland have different regimens despite being neighbors. Look at your own country or your own location's guidelines on TB management, because they will be a little bit different. Let's look at the treatment of leprosy. So treatment of leprosy is with dapsone. It is the most active drug against leprosy. The oral agent penetrates very, very well, and it inhibits folic acid synthesis. We use dapsone in combination with rifampin many, many times. The toxicity of this medication includes GI irritation, rash, hemolysis, especially hemolysis in people who have glucose 6-phosphatase deficiency. Ace-dapsone is another version of dapsone. It's a depot formulation that lasts for months. And we also use this medication in HIV patients to treat certain pneumocystis infections as well. Okay, let's move on to atypical mycobacterium infections. Let's start off with MAC. It's also called Mycobacterium avium complex, or MAC. It's also called Lady Windermere syndrome. It's seen in HIV-positive patients often. It's often involving the right lobe or the right middle lobe. Sometimes you see it in the left lingular lobes. Now, prophylaxis with CD4 counts less than 50 is clarithromycin clarithromycin or azithromycin plus or minus rifabutin. With treatment with patients who have CD4 counts less than 50, we have clarithromycin or azithro plus ethambutol plus rifampin. Other atypical mycobacteria include Mycobacteria marinum and Mycobacteria ulcerans. Obviously, these two are seen in certain demographics. Marinum is often seen in, we used to call this fish workers disease or fish workers ulcers, and Mycobacterium ulcerans is seen in certain diabetic patients with ulcer activity. It's often treated with regular antituberculous drugs. Now here's a CT scan of a patient with right middle lobe consolidation secondary to Mycobacterium avium.